You can begin, Dr. Hoffman.
Okay. All right. So welcome, everyone. We're going to discuss this evening the utility and applications of surgery for children, specifically with epilepsy, and learn how advancements in techniques can stop seizures in some children. So the first topic to address is just defining seizures, what they are, what defines epilepsy within that context. And then beyond that, of those children, which are potentially surgical candidates? How do we decide that? Who needs surgery? This is a big topic. This is a big cohort, of the population. And so something that, demands a lot of our attention, effort, and energy for anyone in the world of pediatrics, neurology, or pediatric neurosurgery. So first, what are seizures? They're the clinical manifestation of abnormal electricity anywhere in the brain. So therefore, they can take on the function of that area of the brain that is experiencing this abnormal electrical activity. So while they can be experienced as is more traditionally understood in the form of an abnormal movement or an uncontrolled movement, an abnormal or uncontrolled sensation, they can also be experienced as an abnormal taste or smell, inappropriate laughter, behavioral arrest, a speech arrest, with very specific types of epilepsy, which we'll discuss in terms of where they're coming from, jaw pain, difficulty swallowing. And even subtle signs that have more to do with the autonomic nervous system in the form of a fast or a slow heart rate, something that is not very easily detectable or externally examinable. Now, when does a seizure become defined as epilepsy? So that is a condition in which seizures either occur unprovoked and separated by 24 hours, or outside of the setting of a trigger and expected to occur again in the course of a child's lifetime. So a child, for example, that has a seizure in the setting of a fever, has no other contributing risk factors to have that occur again, such as a genetic predilection, family history, or another structural abnormality of the brain, would not have epilepsy. That would be an isolated seizure in the setting of a fever. However, if that were to occur again 24, 48 hours later without the fever, or if that child has an underlying condition that places them at higher risk for this occurring again in their lifetime, then that child would be diagnosed with epilepsy. Now, epilepsy carries a incidence of 1 to 3% of the population. 25% of those patients will actually be good candidates for surgery, and actually surgery will hold a much safer treatment mechanism for 25% of children with epilepsy in order to maximize their developmental and cognitive potential. So what is medically refractory epilepsy? So how do we decide who falls in this category of 25%? We define that as those patients who are refractory to medical therapy. And we define that as failure to respond to 2 medications appropriately dosed. There used to be a time limit set on that at this juncture. We typically just utilize failure to respond to 2 medications. So any child with a diagnosis of epilepsy who has not responded successfully to 2 medications actually falls in a category that requires surgical workup. Now, the types of seizures, we'll run through this quickly because we want to focus more on the surgical indications, but just to give a comprehensive overview, can be quite varied. So just as the presentation can be varied, the way that we describe these and type these seizures is similarly complicated. So they can be simple, meaning that the patient maintains consciousness, or complex, meaning that the patient loses consciousness. They can be partial, involving one part of the body, or generalized, involving both arms and legs and involving consciousness. They can be absence, meaning affecting just behavior and attentional arrest. They can be autonomic, again, as we described, affecting just the heart rate. And they can be what's called insular, which comes from a very specific area in the brain called the insula that results in a very specific set of symptoms, including jaw pain and a sense of swallowing difficulty. Now, in terms of causes of seizures, this is just equally as varied, and this is an important thing to recognize. So structural lesions of the brain can cause epilepsy, and this would be the more commonly understood cause of seizures. Mesial temporal sclerosis, or MTS, focal cortical dysplasias, tumors, vascular malformations in any area of the brain. All these are structural lesions of the brain that can result in seizures. However, so can infections that affect the brain more generally, meningitis, encephalitis, herpes simplex virus when it is central and involving the temporal lobes. Also, mass lesions of the brain, abscesses, can all result in seizures. There are also genetic mutations that do not result necessarily in structural lesions, although they can depending on the underlying diagnosis, but they also carry a risk for seizures. One such example would be the SCN1 gene. Another would be tuberous sclerosis that does result in structural anomalies. Strokes are very typical cause of seizures in children, hydrocephalus, and metabolic disorders. So let's just review a history on a few patients to get a sense for the wide variability in presenting signs and symptoms that therefore dictates the wide variability in treatment approaches that are necessary in pediatric epilepsy specifically. And we'll talk about the reasons for those differences. There's a 6-year-old girl. She was sent to the school psychiatrist for what was presumed to be an attentional deficit disorder. She appears to stop, blink, and stare for a few seconds. During these episodes, she doesn't respond or interact. She has no other symptoms during these episodes. She does not shake. She does not lose consciousness. She jumps right back into the action that she was in the middle of at the time of the event, and this can occur as often as 15 to 20 times a day. I had videos of this, although, oh, good, they're going to play. I didn't know if they would. Now, the one thing I have to do is make sure you can see this. So let me hold on one moment.
Jeg husker at pappa sov med meg, og så våkna jeg, og så visste jeg ikke hvor jeg var, og så fikk...
Apologize, this may not work. We may just have to describe. So my apologies. But what that was showing you is the this particular little girl and how she describes these events, in that she just experiences skipping these beats and coming right back in, but not knowing what she's missed. And this is what is often misperceived in schools as attentional deficit disorder, when really these are what we would define as absent seizures. They're quite benign. They will resolve on their own over time, but they do require therapy, and they require appropriate understanding of etiology in order to treat children appropriately and to support them appropriately at school. This is another child who's a 6-year-old boy. He presented differently with laughing spells. He would laugh inappropriately out of nowhere with no appropriate stimulus and in socially inappropriate contexts. He was diagnosed with a behavioral disorder. However, an astute pediatrician referred to a neurologist, and an MRI of the brain demonstrated a hypothalamic hamartoma. I'm going to show you an example of these types of lesions and innovations in the ways these are being treated. And lastly, there's a 3-month-old girl. She was demonstrating repetitive posturing consisting of flexion of one elbow and extension of the other, otherwise known as the fencing position. There was a lack of interaction during these events, but no frank loss of consciousness. On exam, her skin exam revealed multiple ash leaf spots or hypopigmented spots and a rash across the nasal bridge and maxillary region of her face. This child had tuberous sclerosis and multiple intracranial lesions, necessitating a complex workup and multi-staged treatment, which we will review. So, this gives you a feel for the variability with which children can present, and therefore the diagnostic and therapeutic challenge. So, what is so unique about pediatric epilepsy, and why is this such a multidisciplinary category of neurology, neurosurgery, and epilepsy? And the most significant reason is that children most commonly present with much more varied disorders resulting in seizures, dysplastic and hemispheric disorders, usually extratemporal, with a variety of presentations. This therefore leads to a diagnostic and therapeutic challenge that requires a multidisciplinary team to select the correct approach. Additionally, children are more commonly medically refractory. Again, we discussed the fact that the incidence in the population is 1 to 2%, with 25% of children being refractory and requiring a surgical workup. It's also important to understand precise seizure etiology and associated syndromes in children, as they carry a very different prognosis. So there are several benign epilepsy disorders in children. Several are represented here: benign Rolandic epilepsy, childhood absence seizures, psychogenic seizures. These are conditions that are expected to lead to spontaneous remission without treatment or without prolonged treatment, and certainly not surgical intervention, and to be associated with very good prognosis. That's in stark contrast to refractory temporal epilepsy or extratemporal localization-related epilepsy, which is predictably results in cognitive decline. And then there are the hemispheric disorders: Sturge-Weber, Rasmussen's encephalitis. These are malignant and progressive without appropriate therapy. So understanding the difference between the presentations and how they inform our treatment approaches. And the last and most important aspect of pediatric epilepsy that is different when treating adults and children with seizure disorders is the effect of refractory epilepsy on a developing nervous system. Language, motor, cognition. In children, these systems are still developing, and that development is dramatically hindered by the constant interruption of incompletely treated seizures. So these factors indicate early consideration of a surgical workup and intervention in the pediatric epilepsy population. So let's look through the potential differential diagnoses in children and how we have to approach them. So this gives you a sense as to the variability of clinical diagnoses, and therefore the differences in treatment approach we need to take to each child. Cortical dysplasia is a focal lesion of the brain that results from abnormal migration of these cells during embryogenesis. It is not a tumor, it does not progress, but it irritates the surrounding cells, and it requires removal of the lesion as well as any additional surrounding what we would call irritative or epileptogenic brain. In this patient, there's a small lesion in the left frontal region that you can see that looks a bit different from the surrounding brain, and that is the region of cortical dysplasia. Sturge-Weber represents with a hemispheric effect in which one hemisphere is smaller than the other and affected by what we call a peel synangiosis that creates a seizure potential and network of the entire hemisphere. And we'll talk about how we address those hemispheric disorders in association with other systemic abnormalities associated with the classic port wine stain of the face, and leads to an appropriate intracranial workup and these typical intracranial findings necessitating early treatment. Tuberous sclerosis, another neurocutaneous disorder associated with diffuse and widespread intracranial abnormalities, as you can see represented on this MRI here, with all of these variously located bright spots, all of which can represent seizure foci and therefore require a very complex and comprehensive approach towards successful treatment. Hemimegalencephaly, where one side of the brain is congenitally larger than the other and serves as a seizure focus. Rasmussen's encephalitis, where inflammation of one half of the brain from an unknown cause results in atrophy of that side of the brain and needs to be disconnected from the normal side. And then the typical mesial temporal sclerosis, indicated by that yellow arrow, where the hippocampus and the amygdala of the temporal lobe, the most commonly seizure-generating areas of the brain, become scarred and serve as a seizure focus. So as you can see, the differential diagnosis in children, it is variable. It is not always temporal in nature, which in adults it most commonly is. In adults, it is most of the time temporal lobe epilepsy, usually mesial temporal sclerosis with very typical presentation and a very typical treatment needed. This therefore presents substantial challenge in locating the seizure onset zone and a very variable approach in treatment, which can include disconnective procedures, resective procedures, or neuromodulation. We're going to talk about what all of those are. So the way that we define candidacy for epilepsy surgery requires substantial teamwork. The team involves neurology, neurosurgery, neuropsychology, neuroradiology, and neurophysiology. The goal of that team, and we meet weekly to review all potential surgical candidates, is to combine a patient's clinical presentation and to, as well as the data from their workup, which we will review, to identify options for safe intervention. The data that we utilize to determine this is, what do the patient's seizures look like? What does their EEG data tell us about where seizures may be coming from? What does MRI tell us about the structural aspects that might be contributing to where the seizures are coming from? PET, SPECT, MEG, WADA, neuropsych. I'm going to show you the specific data, what they all look like, and how we put these all together to define a given patient's surgical candidacy. So looking at the diagnostic tools that we use to make this determination, there are non-invasive tools and there are invasive tools. We, of course, start with the non-invasive workup first. We utilize EEG, MRI, functional MRI, PET, SPECT, MEG, which stands for magnetoencephalography, and neuropsychological assessments. I'm going to show you what those data look like. If either the data from the non-invasive diagnostics indicates several areas of interest, or the area of interest that they indicate may be structurally or functionally important for the patient, then we move on to invasive diagnostics to better create a safe surgical plan. And those invasive diagnostics can include WADA, subdural grid placement, and stereo EEG. I'm going to show you examples of the tools that we use the most frequently so that you can see what the data looks like and how we put it all together. EEG, everyone is fairly familiar with. It is very well tolerated. It can be performed in the awake patient, and we follow a internationally defined scheme for lead placement. This is a very good tool for a very gross and general assessment of where seizures may be coming from. It is very crude. We can only get a sense for the potential side. Are they coming from the right or the left? Or a very general sense of, are they coming from the temporal lobe, maybe the frontal lobe? But further identifying the spatial resolution of seizures is difficult with EEG. We therefore call upon additional imaging modalities to help us identify the localization site of onset for seizures. This is what a PET scan looks like on the top left here. The way that we use this is to inject a metabolite that indicates where metabolism is upregulated and downregulated in the brain. The areas that are downregulated essentially represent areas of scar that are resultant from consistent and constant seizure activity. So that seizure activity, in effect, damages that brain as the onset zone of seizures, and therefore will result in what we call a cold spot on PET. There will be decreased uptake of that metabolite due to the decrease in metabolism. So in this sequence, image B here shows a large green area where the rest of this heat map or metabolic map in red shows more normal metabolism. That tells us that that green area of dropout is cold, is an area of potential lesion-associated epilepsy. And that can help us target where to place our grid during surgery, where to focus our energy on defining a safe surgical plan. SPECT does the opposite. It actually looks at metabolism and blood flow during a seizure, at the time of a seizure. So this requires a very coordinated team to perform well. There needs to be someone at the bedside that can inject immediately at the beginning and hopefully just before the onset of a seizure. And then it will indicate increased blood flow to the area that is actively seizing at the time. So in this representative schematic, you can see this bright spot in this patient's right frontal region indicates a potential area of interest when MRI is not definitive. MEG or magnetoencephalography can additionally provide further non-invasive data to hone us in on one area or another by utilizing magnetic dipoles in the brain. This is what the machine looks like. This is what the output looks like. These little white dots are dipoles that indicate potential deeper areas of seizure foci. And this is how we utilize this tool to further lend support for or arguments against different areas of the brain being involved in seizure networks and therefore involved in a potential safe surgical plan. Now, if all of those data points are either not fully conclusive or indicate that we need to garner more information to define the safety of removing an area of interest, then we sometimes have to move to invasive diagnostics. Now, the more historical and most invasive way to do that is to place a grid directly on the brain's surface at the time of surgery to close everything and take the patient to the ICU and record directly from the brain. This gives us highly specific spatial and temporal resolution, of course, as you can imagine, as we can record individually from each of these numbers, as you can see, represents an electrode and gives us information of what's going on in the brain underneath it. The drawback, of course, is that this involves an open surgery for the patient, extended time in the ICU, and a lot of patience while we record and hope to capture seizures. This has therefore led to the development and advent of stereo EEG, which instead of that large open procedure uses a robotic interface, which you can see here represented on the left, to robotically place these small little 2 millimeter depth electrodes through very small bony openings that are made through minimal skin incisions. This device can actually be removed at the bedside, does not require a return to the operating to remove, and the patient goes home from there. So the use of this is if we again have to interrogate additional areas of the brain to determine their contribution to a seizure network or their contribution to normal brain functions such as language, motor, higher order functions, and therefore the safety of our proposed plan. This is a minimally invasive way to go about that. So when we've collected all of that data, and that's just a bit of a whirlwind tour through the most commonly used tools and techniques, there are far more and many more layers that we use to put together a potential surgical flight plan. We have to fold in the potential for surgery into the patient's overall treatment scheme. So any patient with new onset seizures, even if they are multiple, will always begin with a medical regimen. Following that medical regimen, the ketogenic diet can also be added in as a good non-invasive adjunct. But again, as we discussed, if a patient breaks through maximal forms of those two therapies, then they move on to surgical candidacy. And based on the data that we obtain from the diagnostic tools we just discussed, we then determine whether a patient is a good candidate for either a more minimally invasive neuromodulatory procedure, which is typically palliative, versus an open resection. So, which can involve either removal of involved brain, disconnection. We also have advanced the utilization of laser therapy or LIT, which I'm going to review in detail in the realm of epilepsy. And at this institution are advancing the potential role of completely non-invasive treatment in the form of focused ultrasound. So neuromodulation, I'm going to touch on briefly, but it does carry substantial benefit for specific patients. RNS, or responsive neurostimulation, involves the placement of a battery or a generator recessed into the skull here so that it is flush with the skull and not terribly visible externally. There is then a lead that is placed over the surface of the brain to detect seizure activity, and then an electrode placed into that area to provide a stimulus to abort the seizure activity. So this would be utilized in the case of either multifocal epilepsy that we cannot directly pin down explicitly enough to warrant a surgery, or in the case where the area that would need to be removed is of high functional value to the patient, either involving dominant language cortex or motor cortex, primary sensory cortex, et cetera. This would be a minimally invasive method of trying to abort seizures as they occur. The efficacy is good. It is not nearly as high as an open resective procedure, which can be curative. So that's why this falls in the palliative range. But some patients can gain between 60 and 80% of seizures if they are a good candidate for this procedure. Vagal nerve stimulation is also a very good palliative option for patients that have generalized seizures where we cannot or should not, based on the location of interest, remove or disconnect the associated seizure network. This involves a lead placed in the neck around the vagus nerve. This lead is then tunneled down into the chest. There's a very small battery. It's much smaller than this now. It's about half of this size, is placed on top of the pectoralis muscle. These generators are barely noticeable to the patient. And there is not only constant stimulation, but we now have closed loop systems that can actually respond to a patient's heart rate to predict a seizure and to deliver a higher rate of stimulation. Again, the typical reported rate of response is approximately 50% reduction of seizures in 50% of patients. However, in the correctly appropriated patient, selected patient, or in very good candidates, we can actually see seizure control rates of upwards of 80%. Now, moving into what we would consider open resection or curative stage procedures, we can perform resections of any lesion in any lobe that is the lesion is involved. This does require, as we already indicated, some workup if that area involves eloquent or necessary cortex. But we can often, with a multi-stage procedure or appropriate mapping intraoperatively, safely remove lesions in essentially any location. The workhorse of this approach would be the temporal lobectomy. The most common indications for this are mesial temporal sclerosis, as we indicated, or that scarring of the mesial structures in the form of the amygdala or hippocampus, temporal lobe tumors, or focal cortical dysplasias involving the temporal lobe. The typical incision utilized is indicated here as a question mark above the ear, allowing for a bony window that is indicated here, allowing us access to what is indicated in green, that anterior temporal tip, and then the mesial structures, the amygdala and the hippocampus more medially. When you look at this from the bottom up, it gives you a better 3D sense of what we need to remove to treat these patients successfully. Patients do very well. This is extremely well tolerated if the patients are selected well and the appropriate preoperative workup is performed to keep them safe. And response rate in terms of seizure control can be quite high and curative in the right patient. This is an example of a patient who is 16 years old presenting with refractory seizures. She had experienced behavioral arrest, progressing to depression and a steady cognitive decline in school. Her EEG indicated that these were likely coming from the left temporal region. Her MEG also indicated left temporal dipoles. A PET study also confirmed left hypometabolism in the mesial temporal region, and a WADA that was performed, which essentially through the injection of a substance that puts one side of the brain to sleep at a time and then allows you to perform neuropsychological testing to essentially simulate what removal of that area would impart on the patient. You can test language and memory to ensure that it is safe to proceed with a resection of that side. Indicated that language actually existed on the right side for this patient, which is contrary to typical language dominance, and therefore indicated that it would be safe to resect this left-sided lesion. You can see the lesion represented here in the left mesial temporal lobe of this patient. This is an MRI following that resection. It was performed with what we call ECOG, which is a type of recording directly from the brain surface that we can do at the time of the surgery to confirm our findings that the lesional area is contributing to the seizure network, and also to ensure that we remove any surrounding irritative cortex that's contributing to that abnormal seizure network. That patient was then seizure-free and steadily improved in her cognitive processing and her depression after surgery. Moving into the disconnective procedures, it requires an understanding of what we call the limbic system, which is the deep white matter structures of the brain that connect together to propagate seizures throughout the brain. So they can start in one area, but they spread very quickly to another, and that's what leads to what we call generalization. So a patient that may start with just shaking in one arm and then progress very quickly to loss of consciousness and shaking of both arms and legs. The seizures have created that spread and spread from one area of the brain to involving all areas of the brain so quickly by using these white matter highways that are typically described as the limbic system. So this is a really nice representation on what we call DTI, or diffusion tensor imaging, of those white matter tracks. And this is the system and the structures that we need to disconnect in order to isolate a given patient's seizure network from the normal brain, when we do not want to resect a large area, or if it is unsafe to do so. So you can see these large connections from the temporal lobe all the way around the frontal lobe and up into all areas of the brain, utilizing large white matter structures, the largest of which is the fornix. However, the arcuate, the fasciculus, and basal frontal fibers also serve as large highways, as well as the corpus callosum, connecting the right and the left brain. This is an example of how we can use these tractograms, if you will, or diffusion tensor imaging to create safe surgical plans. This is a cadaveric indication of where our optic radiations project. This is within the temporal horn of the temporal lobe, which is an area that we are operating in quite frequently, as we just reviewed, by looking at the approach for a temporal lobectomy and the frequency with which we're working in the temporal lobe to treat patients with epilepsy. In performing diffusion tensor imaging, we can actually map these white matter fibers and tracks of the optic radiations to try and do our best to create a surgical plan that spares vision in certain patients, depending on where their lesion is. So how do we use disconnection to help patients with epilepsy? So hemispheric disorders is one of the most common applications of disconnective procedures. Hemispheric disorders, we've gone over a couple of examples, most commonly present in pediatric patients in the form of either hemispheric perinatal strokes, hemimegalencephaly, Rasmussen's encephalitis, and the neurocutaneous disorders such as tuberous sclerosis and Sturge-Weber. Now, this used to require a complete, what we call hemispherectomy, meaning a removal of one half of the brain or the diseased portion of brain to allow the normal brain to develop normally, and therefore stop that abnormal side from talking to the normal side and constantly disrupting the normal brain's function. Now, this procedure has advanced dramatically over the last decade to a functional hemispherotomy, which is a much more elegant procedure, which is performed from within the ventricle entirely, leaves the rest of the hemisphere in place, and simply disrupts those white matter tracks that I was just showing you in taking down the highways of communication between the abnormal hemisphere and the normal hemisphere, thereby substantially decreasing risk, morbidity, and improving recovery from this procedure. The only access points that we need for this procedure are seen here, with these very small cortical windows that allow us access into the ventricle, with the remainder of the procedure being performed from within the ventricle only. This is the typical incision and bony access performed with the ventricular system highlighted behind that bony window, indicating how this procedure is performed. The complication rates that have been decreased with this procedure are the needs for shunting postoperatively. So this used to carry a risk of shunt dependency of 80% that has dropped down to 10 to 20% with hemispherotomy. There was also a condition called hemosiderosis following a full complete hemispherectomy, which was progressive and fatal, which has essentially gone away with the advent of hemispherotomy. And functional recovery is substantially better with this procedure, with almost all patients ambulating after with only loss of fine motor control, and all patients seeing substantial cognitive and functional improvement. We took a look at this in detail when I was a fellow at the Hospital for Sick Children with Dr. Rutka. We looked at our Rasmussen's encephalitis population to advance the management of these patients by improving understanding of patient outcomes, and to encourage the early use of this procedure by demonstrating functional outcome. In our patients, 100% were ambulatory after this procedure with the use of an AFO in 72%. 90% of patients experienced improved cognition, with 10% experiencing stability and an arrest of their cognitive decline. 100% experienced improved seizure control, with 63% of those following the highest class of control, or ILAE class 1. 36% of patients were able to come off of medication, with the remaining 63% tapering their medication, and a very, very, very low complication rate, with only one patient requiring lumbar drainage secondary to a small fluid collection, and this was then removed. We did not have to shunt a single patient. So with the increased understanding of the clinical utility and the low morbidity of this procedure, we are starting to be able to treat patients with hemispheric disorders much earlier with far better outcomes. This is a 5-year-old male who had normal to advanced development, no history of trauma infection, who in 2001 presented with acute onset of seizures. He progressed quickly to something called epilepsy partialis continua, which means a portion of the body in this child, it was his left upper extremity and face, seized constantly. He became medically refractory very quickly, and imaging studies demonstrated a potential Rasmussen's encephalitis, meaning that there was inflammation of the entire right hemisphere. We do not know the precise etiology of this. His MEG supported this with these dipoles involving the entire right hemisphere. EEG supported this as well. He underwent 1 round of medical therapy with what we call IVIG with no improvement, and underwent very rapidly following this a right-sided hemispherotomy. Within weeks, he recovered to mobilizing well with an AFO. He returned to school shortly thereafter, and Jack actually went on to go to a very good college and is an extremely high-functioning kiddo at this point. You can see him holding his left arm up. It's just that hand that he doesn't have fine motor control of, but the rest of his cognition and functional outcome is excellent. The next disconnective procedure to touch upon is the corpus callosotomy. So the biggest indication for this is atonic seizures, otherwise known as drop attacks. So children that drop their head suddenly, or in more severe cases, their whole body. They are excellent candidates for this procedure. You do need to be aware of the disconnection syndromes that can follow, and hence the need for potentially an anterior 2/3 versus a complete callosotomy. The disconnection syndromes that can be seen are listed here. Most commonly, there is an SMA syndrome or an alien hand syndrome, whereby the patient will experience typically an intermittent and temporary, but it can be permanent, disconnection from their hand, or motor processes involving the hand and the arm with a limited ability to carry out motor processes in one limb or the other. This is typically short-lived, but it can be longer lasting. And then there are other aspects of disconnection syndromes, if we complete the disconnection to include the posterior corpus callosum, that also include spatial, not only neglect, but processing with respect to language and reading. We see agraphia, we see alexia without agraphia, and it just depends on how far back the disconnection is carried. Now, again, in some patients, those types of symptoms would not be relevant depending on their baseline language and cognitive function. But in patients that are very high functioning, this has to be paid particular attention to. Performing only an anterior 2/3 at the outset, minimizing and limiting those disconnected procedure syndromes, and seeing how much mileage you can get in terms of seizure control. The major advancement here is laser therapy for callosotomy, which we'll review when we discuss LIT. The access point for callosotomy looks like this. It's a horseshoe incision on the top of the head with a bony window that crosses midline 1/3, and the other 2/3 of the craniotomy is on the ipsilateral side of midline. This procedure is a nice procedure because there's absolutely no direct brain dissection. The approach is between the two hemispheres along what's called the falx. This is a view from the top down. That dissection is carried down to what we call the paired pericallosal arteries, and between them sits the corpus callosum. And we simply use suction and bipolar cautery to make a midline incision in that structure as far forward and as far back as we can visualize and as is safe. This is very well tolerated procedure. Again, if only the anterior 2/3 disconnection is performed, any post-operative morbidity is quite minimal. Now, the use of LIT for callosotomy is gaining a lot of attention and utilization. This is a use of laser interstitial thermal therapy, or LIT, for the purposes of targeted tissue disruption. And in this case, it's the use of two different trajectories to perform a corpus callosotomy. You can see this dark artifact that is created by the placement of the probe from a single occipital burr hole straight through the body of the corpus callosum, and then an additional burr hole in the frontal region carrying the probe down through the rostrum, leaving the splenium intact. I'll review what LIT looks like in a moment. This is an evolving and minimally invasive option for patients in which either open surgery is not palatable, or they have already had another surgery, increasing the risk of opening dura in that region, or they have other medical comorbidities limiting their surgical candidacy. The last disconnective procedure is a temporal parietal occipital disconnection. This is a very elegant procedure for patients in whom motor function is full, and you want to preserve motor function, different from that loss of fine motor in the hand that I demonstrated with a hemispherotomy. This is a procedure that is performed with this red cut line here behind the motor area, motor cortex and sensory cortex being represented just anterior to this red line, and down into the temporal lobe. This is a very simple procedure. It only entails disconnection along this line, leaving the remainder of the brain intact, and is very good for patients who have posterior and temporal etiologies of their seizures and are otherwise very high functioning, as it will not incur any additional motor sequelae for these patients. This is a patient of ours that had a very large left occipital parietal focal cortical dysplasia, but had very good hand function and could ambulate independently. And you can see this cut line here on the postoperative CT. She did very well from the surgery and has been seizure-free since. So looking at some advancements, LIT and pediatric epilepsy has seen a substantial increase in utilization over the last decade. While we know that surgery has a very substantial efficacy with 70 to 80% seizure freedom, due to concerns over invasiveness and potential morbidity, we often incur late referrals of patients for surgical intervention, and only a small percentage, unfortunately, of refractory patients may come to us for referral. Therefore, the utilization of more minimally invasive techniques has the potential to increase referral rates and increase patients that could substantially benefit from surgical approaches. The etiologies that are best treated with LIT are those that are deep-seated or bilateral, and therefore would be difficult or carry high risk and high morbidity profiles from an open surgical standpoint. Typically, that would be tuberous sclerosis with bilateral and deep-seated lesions, hypothalamic hamartomas that are very central in the brain, very difficult, high morbidity open surgical approaches to these lesions, cortical dysplasias that are deep or multiple, periventricular nodules, also very deep lesions, or mesial temporal sclerosis in patients that have either undergone prior surgery in that region or who have substantial risks for open surgery. The advantages to this are that it does not use ionizing radiation as SRS does. There is potential for retreatment because of that lack of radiation. And we can obtain real-time damage estimates that we can see through the use of MR thermometry. So these are the major differences between LIT and other minimally invasive techniques, such as stereotactic radiosurgery or even focused ultrasound. This is just an indicator of how pediatric epilepsy and the application of LIT in this population is gaining substantial academic attention and activity. This is what the lasers look like. There is a diffuse and a targeted tip. The probes are then advanced to your target through a small burr hole in the MR machine. And the probe is activated and heated with active real-time thermometry feedback. So this is what the map looks like as we are administering the thermal therapy in the scanner in real time. So it tells you where your core heat is being delivered, the extent both anatomically and where the temperature ranges are reaching. And so therefore you can either stop, tailor, adjust, and redirect robotically where you would like to deliver your thermal insult, and also to ensure that you limit any unanticipated off-target effects to surrounding tissue. This is also a nice application for this etiology we were discussing at the beginning, hypothalamic hamartomas. These are lesions that are developmental anomalies that result in gelastic seizures, as we discussed in the beginning, with inappropriate laughter, also associated with neuropsychiatric symptoms and precocious puberty. Postoperative seizure control rates correlate with preoperative seizure duration, meaning the earlier we can treat these children, the better our ability to control their seizures. Now, the treatment options historically were open resection, stereotactic radiosurgery, endoscopic disconnection from within the ventricle, or now LIT. The advantages of LIT being immediate efficacy, which is a definite advantage over stereotactic radiosurgery, a very sharp border delineation compared to SRS, decreased risk to adjacent structures as compared to all three, open resection, SRS, or endoscopic disconnection, a reduced hospital stay from open resection based on the minimally invasive approach, and the complications that are expected and are decreasing as experience and learning curve improves is inaccuracy of probe placement, and in some cases, incomplete dural openings that can cause epidural hematomas as those probes are placed. But this is a very nice evolving approach that provides a more minimally invasive and tolerable treatment option for these patients. Now, lastly, to leave time for some questions, if there are any, the advancement of the use of focused ultrasound in the realm of epilepsy. This is a very new and evolving, completely non-invasive approach towards the treatment of very deep-seated intracranial pathologies that can be treated with very, very small lesions. So focused ultrasound looks like this in real-time reality, where the patient is secured in a head frame that is then advanced into an MRI scanner to allow for localization of a target that then ultrasound waves are advanced upon. This is what the planning images look like, so that you can see how many ultrasound beams are focused on a single point, the target being typically 2 to 3 millimeters. The initial applications of this, especially our institution, have been for the treatment of movement disorders in replacing or mimicking deep brain stimulation with the same thalamic targets. Tractogram generation is essential in identifying the tracks that are targeted for disruption, and therefore then determining in real time immediately following therapy that those tracks have in fact been lesioned and disrupted. The seeds for cortical spinal tract, medial lemniscus, and dentatorubro-thalamic tracts are indicated here. This is a very specific institutional protocol that we have used with Dr. Michael Caplet in developing unique strategies for ensuring complete treatment effect and predicting clinical success in the use of focused ultrasound for disrupting deep white matter tracts. So you can hypothesize and understand where this would be applicable in the world of epilepsy surgery in targeting the outflow tracts potentially of the temporal lobe and treating mesial temporal sclerosis, as well as in performing small white matter tract disconnections in patients that have undergone larger open resective and disconnective procedures with seizure recurrence from small couple millimeter white matter tracts that would be amenable to focused ultrasound ablation. This is another demonstration of that real-time thermometry that we can achieve with focused ultrasound. We can identify eloquent structures of interest surrounding our target, for example, optic radiations, and monitor the thermal environment of those and thermal exposure of both our target as well as those structures of interest to minimize any off-target effects. So taking all of this into consideration, it's a whirlwind tour through, the focus on pediatric epilepsy, how we identify surgical candidates, and the substantial utility of surgical interventions in the pediatric population. And to get a sense for the fact that both surgical techniques as well as minimally invasive technologies are all expanding the surgical options for epilepsy in children. These tools therefore provide us the opportunity for earlier and substantially more effective treatment in children that allows them to see much greater cognitive potential, better functional and developmental outcomes, increased rates of not only seizure freedom, but also instance of being able to be free of medications that carry a substantial risk when used for a lifetime. And just present, in many cases, actually a much safer approach towards seizure management in the pediatric patient. So bearing all of that in mind, surgical candidacy should really be assessed in all children refractory to 2 medications with the goal of limiting functional decline and improving quality of life for these children. So with that, I thank you, and I, of course, take any questions and look forward to hopefully collaborating and hearing from all of you in the future.
Thank you, Dr. Hoffman. Have a nice night, everybody. Dr. Hoffman, are you still there? There is a question in the chat box. Sorry about that. Thank you. Sorry about that. I'll refer the question to Dr. Hoffman. Thank you again. Have a nice night.